I'm Hans Morefield, the CEO of Chess Health. I hope you're having a great day today at this Digital Health Summit. Hopefully, you can't tell that this is like take 14 of me trying to record this video at home on my Zoom. Sometimes the recording ends too long, sometimes someone knocks at the door, sometimes I stumble over my words. I don't even think I even had this gray hair when I started this like an hour ago. Anyway, we're really excited to have the opportunity to share our story today, and importantly, share two case studies from two important projects and projects we're really proud of. We're going to be talking about our implementations in West Virginia and Oklahoma, two statewide projects where we're working closely with both the state governments, but with treatment providers across those states to help thousands of individuals, helping thousands of individuals with their treatment and their recovery from substance use disorder. And in the case of Oklahoma, also helping to get more individuals to treatment and to help their family members in that recovery journey as well. Before I get into those projects, I want to briefly introduce a little bit about Chess Health and who we are and the breadth of the solution portfolio that we're going to be talking about when we talk about the West Virginia and Oklahoma implementations. So let me tell you about Chess Health. Chess Health is a technology company focused on the personal and societal crisis of substance use disorder in the United States and internationally. We started with a smartphone app that came out of the University of Wisconsin. The professor and the developer of that app, Dave Gustafson, was a co-founder of Chess Health. It's an evidence-based solution that had been demonstrated in numerous clinical trials to help individuals achieve longer recovery, increase their sobriety, and importantly, reduce rehospitalization rates. But we've built on that initial smartphone app and now offer a platform for the life cycle of substance use disorder, not just helping individuals in recovery, but enhancing the treatment they get from their provider organizations, helping to get more individuals to treatment through our intervention platform. And most recently, we've been working at adding, with the support of the National Institute of Drug Abuse, adding prevention functionality to our platform. In the long run, our goal is that we're going to be preventing substance use disorder in the United States, and then as necessary, helping to get individuals to treatment for it when necessary and to support their lifelong durable recovery from a terrible disease. Now, this breadth of a platform from prevention to recovery naturally attracts a lot of, is naturally relevant to a lot of stakeholders in the space. We mostly work with provider customers directly. They contract with us to use our technology with their patients, with their alumni, with their community referral sources, with other community programs, and we make an impact on their clinical operations, their clinical outcomes, and their business and their adherence and the number of patients they serve and the amount of services they offer to those patients. But we also work with payers and governments and other organizations that want these same kinds of outcomes for their citizens and for their members. And today I'm going to be specifically talking about Oklahoma and West Virginia, two implementations, two states that have invested and found the funds for the Chess technology, that have asked us to implement it and make the impact, working with the providers in their community on a statewide scale. So let me elaborate a little bit on these solution sets. Again, I mentioned that we started with the Recovery app, which was known at the time as HS, the letter A followed by the name Chess. We renamed this app as the Connections app in 2018 to reflect really what it offers individuals. It offers them connections to a supportive peer community, other patients who are in treatment at their provider, from their health plan, or potentially in their state or across state lines, a supportive peer community that they can reach out to and learn from and benefit from, and a peer community to whom they can provide support, which can be therapeutic on their own. These are discussion groups that are moderated by Chess and or our customers, or some combination of the two. Now, it's more than just a social platform. This is also a platform that connects individuals to their care teams. And importantly, one of the things individuals do on our app, or actually everything they do in our app practically, is visible to their care team, including critically the completion of weekly and monthly and sometimes even daily surveys that capture how they're doing, their confidence, their challenges, what's going well, what's not, so that their care team can provide feedback-informed treatment to them. There's a whole host of other features here, and if you go to our website, there's a great explainer video that goes through all the capabilities of the app. But originally, one of the features that wasn't in the app was actually teaching recovery skills. And we've subsequently addressed that through a partnership with Dr. Kathleen Carroll of Yale University. Dr. Carroll is an expert in cognitive behavioral therapy for substance use disorder, and she created a great set of online education programs for individuals to teach themselves to learn at their own pace through engaging programs, interactive quizzes, and videos, practical recovery skills that have a durable effect on recovery. And so this combination, these CBT programs are now part of the Connections app, and it's really bringing together two great evidence-based solutions in one. This is the program and the combination that's being implemented and is live and is being rolled out across West Virginia. It's also across Oklahoma. Now, in Oklahoma, they're also implementing eIntervention. Now, eIntervention is our new solution for getting more individuals to treatment, and it comprises two components. One, it's a referral management platform that connects entities in the community for electronic referrals. And in the interest of time, I sort of will breeze through this a little bit, but it's emergency rooms at hospitals and drug courts sending referrals to local treatment providers, to community service organizations for both SUD, behavioral health, and social service referrals. But the other interesting and unique thing about eIntervention is that it includes its own app, an app for the individuals and or their family members to get support and to motivate and facilitate them to actually follow through on the referrals. Their needs pre-treatment are different than their needs and what they're willing and interested in doing once they're in treatment and committed to their recovery. And that's why we have a purpose-built app that varies in terms of what it offers, whether it's an individual or a family member based upon their disease and so forth. But it's there to impact their readiness for change and keep them connected and engaged to follow through on referrals at a higher rate. And we'll talk more about this when we get to the Oklahoma review. So across the breadth of what we do here, of course, we're making a lot of impacts. So we're keeping individuals sober longer. When they do use, the data shows they, like for example, individuals who struggle with alcohol, they have fewer, heavier drinking days, which is important because ultimately it's about reducing rehospitalization and retreatment. We're measuring that more individuals are getting to treatment, and a lot of great evidence that's visible at chest.health/evidence. Now, what I want to focus on from an evidence perspective is one particular study that came out in the study was published in 2019. It was based upon a study that occurred in 2018, and it was done with the HS app, the Connections app, by the University of Wisconsin in southeastern Kentucky. And so while this app was originally developed years earlier, Dr. Gustafson continues to test it in different implementations to learn different things about the app and how it can work. And so one of the questions would be, can this work with impoverished women struggling with opioid use disorder in a very rural part of the country? And that's what this study looked at. Would they use the app? Would it help them stay in treatment longer, which is so critical to recovery from OUD? And the answer was they will and they do, and it does. These individuals stayed in treatment 56% longer than the cohort that didn't have the app, and they engaged in more treatment. They completed twice as many group sessions. They went to 2.5 times as many individual one-on-one sessions. They went to more AA meetings. They took advantage of more case management services. The more intensive recovery, and they used the app at a high rate. When the study completed, after they had 5 months of use of the app, after 5 months, 47% of these women were still using the app after 5 months. It's a phenomenal utilization rate, given this population, given it's a digital mental health tool, when sometimes retention rates are 5% after 30 days. I mentioned this study among the dozens that have been completed with our technology, because it was particularly relevant to the state of West Virginia. Of course, this was southeastern Kentucky. It's Appalachia, just like West Virginia. The situation was very similar, and West Virginia has been looking for solutions to its opioid use crisis. And so this study became, was something that the West Virginia University became aware of. Then when when the pandemic hit and there was this desperate need to help individuals who couldn't get to treatment anymore, who were struggling with isolation, the state came to us and said, we're really interested in this tool for a statewide implementation. Our first conversations with the state were on March 31st. This was, as you may recall, sort of the height of the pandemic. 3 weeks later, we had the agreement and the implementation plan worked out. It was announced by Governor Jim Justice, and a week later, we were live. The first providers were live 7 days after the contract was announced. The first patients are live. The rollouts now at 9 providers are live, and 32 are scheduled to be live by the end of June. Let me just sort of illustrate what this implementation looks like from a visual perspective, because this is another key detail. It's not just an individual with an app. What I've tried to convey is that, it's really important that an individual's care team be connected to them through the app, that they can provide support. They can see how they're doing. They can get survey data out. They can see their completion of modules. They can message with them. They can send them reminders. They can remind them of appointments. They can push them specific content. Great functionality for engaging a patient and a provider. But what was really key in West Virginia is they have a lot of providers, and they're a big believer in the hub and spoke model. And so there are situations where individuals actually have multiple providers at once. They go to one provider for this, and they go to another provider for that. So for example, I go to the hub and I go to the spoke. And maybe there's another organization in my community that's actually the one that's providing me a peer. And what we can do in our platform, perhaps uniquely, is actually connect an individual, a patient, through the platform, through the app, with all of these different providers simultaneously, with the appropriate privacy walls between them. And in fact, right now, as I mentioned, we're doing this accelerated rollout across West Virginia's providers, 32 by the end of June, 60 by the end of September. Now we're also in conversations with all 3 Medicaid managed care organizations in West Virginia about getting on the database as well. They're all interested. Their care teams can also be connected to these individuals at the same time that these individuals are connected with their provider care teams. It's really powerful and important, and it was really critical to West Virginia that they had this sort of patient-centric design. The patient uses one app. It gives them connections to a peer community, and it gives them the connections to their broad care team. And what we're excited about is that West Virginia University, because we love the evidence and we love being part of research, is going to be doing the analytics around this utilization of the platform and the corollary to the long-term outcomes of these individuals. So stay engaged with us, and we welcome giving you updates on this important project. Now, West Virginia wasn't actually our first statewide implementation. In fact, Oklahoma was our first statewide implementation. In fact, Oklahoma was our first customer. We're a New York-based company, but back in 2015, we got contacted. It was actually even before I joined, for our technology to be used as part of a new prison diversion program in Tulsa. Unfortunately, Oklahoma has one of the highest rates, or maybe the highest rate, of female incarceration in the United States. And 80 or 85% of this incarceration is related to substance use. So a great program was started at Family and Children's Services in Tulsa around this prison diversion program called Women in Recovery. And they wanted to offer them a smartphone app as part of their long-term treatment and to offer to these individuals as alumni. We've been proud to be part of this program since its inception. We have had supported thousands of women through this program and as alumni, and I think the recidivism rate is something like 4%. That first implementation with Women in Recovery introduced us to the state leadership at Oklahoma, a leadership in the mental health and substance use side that's really progressive and innovative and forward thinking in their use of new models of care and including use of technology. And so we've been progressively expanding our implementation across the state. So it started with that eRecovery program. We've now deployed eTherapy across 15 providers, eRecovery across 15 providers. But I want to talk to you today about Oklahoma's use of eIntervention. This is our new platform for connecting individuals, facilitating getting them to treatment. And a couple of slides just to give you a little visual of this. Again, what eIntervention is about getting an individual who's referred for treatment, either at a referral site or through a call center or a PCP visit, to actually follow through on a provider. Lots of referrals are made, but the follow through is much, much too low. And so eIntervention is a network solution that connects entities in a community to facilitate electronic referrals, not just one way, but the closed loop status of these referrals so that both providers are always on the same page and work together to get an individual to treatment. And so we get great outcomes data on these referral follow-throughs, which I'll speak to in a moment. But eIntervention is more than just a referral management system. And by the way, a referral management system optimized for behavioral health and the unique requirements around privacy for patients with addiction. eIntervention also includes the Envoy app, as I mentioned earlier, an app designed to facilitate that referral. So in Oklahoma, individuals who are leaving the emergency room have a digital referral to a provider in the community, and they or their family member might be downloading the Envoy app in order to have all the referral details there, but importantly, to be motivated and informed through video content, including videos of other Oklahomans sharing their stories of addiction and recovery, videos of the treatment provider, videos from experts, videos that motivate and inform them, and secure messaging so that both parties can stay connected to this individual, support them, and engage them to encourage them to actually follow through on the referral. Today in Oklahoma, and again, this is an implementation that's also in progress. It's been a little bit slowed by COVID, unfortunately. We've been very busy in Oklahoma with the Connections app and eRecovery during COVID. The referral work has slowed a little bit. And I think everyone's familiar with the fact that fewer individuals are starting treatment during this COVID crisis. And unfortunately, that means things are going to be, it's going to partially be what contributes it to being worse when everything resumes. But today in Oklahoma, we have 40 entities on our network, including 22 SUD and behavioral health providers, hospital emergency rooms, crisis centers, referrals from MAT clinics, a district attorney's office, and family and community services. And the data is early, but the data is evolving and growing and really interesting and already being used for change. And I want to explain that a little bit right here. So one of the challenges is that organizations have never really known how many referrals they got. They haven't really known good data on where all the referrals came from because they only knew about all the people who actually followed through on treatment. And now what we have is data by provider, and this is data from 3 high-volume providers, actually high-volume senders of referrals in the Oklahoma City market, specifically around evaluation and assessment visits. These are really important visits because we're trying to get people to treatment. And briefly, I want to be sensitive to time here. Provider B, their referrals have the lowest success rate. And this data and the comparison of how they compare to their peers is driving changes at provider B, and at the same time is driving some providers to wonder about who they should be sending the referrals to. And so we're getting really interesting data on referral success rates, both by facility levels, as well as the ability to compare them down to different substances of use, compare how those referral outcomes change when they're amphetamine use patients versus alcohol use patients. So a lot of great data coming out of this Oklahoma project. And again, more data will be shared, and particularly more activity will be occurring as this COVID epidemic ends, and unfortunately, more and more people will need treatment in the state. So in closing, I want to come back to this page just to emphasize one key thing again. While we talked about 2 states, it's really about the impact of the providers. We're huge believers in digital health at Chess. Obviously, we're a technology company. We're focused on SUD. We're all about patient engagement. We spend all day thinking about how we help individuals in the app, but we also spend equally as much time thinking about how we help the provider help the patient and how we make all of this work within the provider's workflow. And we know that that provider engagement is going to vary. Some providers can be very active. Some can be only have time to be mostly passive. But we think that's the critical element to digital health success. And if you're interested in discussing this more, please reach out to me personally at hans.chesshealth or visit our website. We love talking about this. We love talking about what we're doing, sharing what we've accomplished, learning from you. So that's why I'm excited to get back to the rest of this conference. Have a great rest of the day. Have a great rest of the summit. And I look forward to speaking with you soon.